Thank you, Luca, for the kind introduction. Good morning, everybody. It's a great pleasure to be here to talk about the DAWN trial. Doing this on behalf, what looks like these slides are being cut a little bit, but doing that on behalf of all the DAWN investigators, including my partner, Tudor Jovem. Here is the study organization of our trial, so pretty standard with independent core lab, steering committee, DSMB and a CEC, as well as an independent statistical core lab. So in terms of background, we all know that the previous available evidence is that, again, time is brain, but the suggestion from the Hermes meta-analysis was that just around 7.3 hours, there would be no benefit for thrombectomy anymore. However, that was largely based on unselected patients, so just like the overall population. And that was reflected in the American Heart Association and ESO guidelines that use very rigid therapeutic windows as level 1A evidence. Having said that, there was a lot of research trying to use mismatch as a surrogate of salvageable brain, and whether it's the clinical core mismatch or perfusion image mismatch, that paradigm had to be tested, and that was exactly what was done in the DAWN trial and in the Diffuse 3 trial. In terms of healthcare importance, the expectation was that we would increase the number of treated patients by about 40% by expanding the window from 0 to 6 all the way to 24 hours, because as we all know, about 20 to 25% of our strokes are wake-up strokes, and then on top of that, you have another 15 to 20% of strokes that present after the 6 hours. So our objective here was to demonstrate superior function outcomes using the utility-weighted MRS, and we will discuss that in more detail with thrombectomy performed with a stent retriever device, in this case the Trivo device, as compared to medical management alone within the first 6 to 24 hours from time lasting well. In terms of the design, this was a global multi-center adaptive probe type of design. The study was that had the FDA oversight because you wanted to apply for changing label of the device. In terms of target vessel, it focused only on intracranial ICA and the M1 segment of the MCA. Patients could have tendon lesions and angioplasty was allowed, but the FDA did not allow for stenting of the extracranial lesion because they consider that a different treatment. Our sample size was planned for a total of 500 patients maximum. At 150 patients, we would have our first futility analysis, and then at 200 patients, we would have our first efficacy analysis, and thereafter, for every 50 patients in the trial, we had an interim analysis. So here is the workflow of the study, essentially wake-up patients and patients presenting after 6 hours all the way to 24 hours. They present to the hospital and they were screened. They had to have an age equal or greater than 18, and IH stroke scale at least moderate to severe, meaning equal or greater than 10, a good baseline function status with an MRS 0 to 1, and then time lasting well to randomization had to be within 6 to 24 hours. We exclude large infarcts, greater than a third of the MCA, and you documented an occlusion on CT angiogram. And if that was the case, patients could undergo CT perfusion or MRI using the automated rapid software. And then you classify the patients in 3 groups according to age, stroke severity, and infarct size. So the first group was the elderly patient, older than 80. They had to have a moderate to severe stroke and IH equal or greater than 10 and a core less than 2 and 1, because the older patient is more sensible to larger infarcts. If you were younger, your NIH equal or greater than 10, and you could tolerate infarcts all the way to less than 31 cc's. However, if your NIH was more severe, equal or greater than 20, you include cores all the way to less than 51. If that was the case, you obtain informed consent, and then you randomize the patients 1-to-1 after stratifying by these 3 subgroups, as well as site of occlusion and time lasting well to randomization to the control and thrombectomy arms, and you follow the patients with 90 days, and you had these 2 primary endpoints. So there were two endpoints. The first one was the average utility-weighted MRS. You're going to talk about that in some more detail. But we also had to not only win here, we also had to win by the 0 to 2 MRS at 90 days. The primary endpoint was stroke-related mortality at 90 days. The secondary endpoints were very similar as in other trials. So it has become a very important point now in stroke to understand that you have different outcome measures and you really need to refine the way you look at outcomes. So you can look at dichotomized outcomes with independent outcomes, 0 to 2, versus lack of independence. The problem here is you don't really gain anything when you transition a patient from these different states of stroke severity, okay? So it's a very crude way of looking at results, and you only have good results versus bad results, when in reality, when you have a treatment, is you don't want to have a good outcome. You want to have a better outcome than if you had not treated that patient, and this paradigm disregards that. So you came up with the 90-day MRS shift, the ordinal shift analysis, that like what was used in Swift Prime, for instance, and then here for every shift in the disease state, you actually add a value, but that value is uniform across the spectrum of the MRS. With the utility-weighted MRS, you compute these shifts, but we figure that all these shifts have different values for patients and families. For instance, we have 7 levels in the MRS, and if you all had 7 family members with 0 to 6, and I gave you 1 point to move one family member, I guarantee to you, you would not move that family member from 1 to 0 or from 6 to 5. You probably would move from 4 to 3 or 3 to 2, okay? Because those are much more important health transitions in the spectrum of the disability. So that's what this utility-weighted MRS accounts for. So it's a much more patient-centric way because the modified rank scale is not a linear scale. These jumps should not have the same value, and that's the importance of this concept. So here is what happened in the trial. We had our 150 patient analysis. You passed the futility boundary. At 200, the DSMB start meeting, and then you kept enrolling patients, and then when you were at 206 patients, they said stop. You have crossed the boundary for early efficacy, okay, as it was pre-specified. Here is one of the patients you put in the trial. You can see this was an ICAT occlusion. This patient was 91-year-old in my center, had a modified rank scale at 90 days of 0, okay? So again, you should not treat patients based on chronological age, but rather on biological age functional status. So the results have now been published at the New England Journal of Medicine, and then you had Diffuse 3 also published a few months later. Essentially, 206 patients were randomized, 99 in the medical arm, 107 in the thrombectomy arm. We had outcomes in 100% of the patients through 30 days, and you lost very few patients to follow up between 30 and 90 days, and those results were carried forward after modeling using the Bayesian design. So demographics, things were well balanced. You can see similar age, around 72. Median age stroke scale was just like Swift Prime and other trials, around 17. We can see here that we had up to 13% of the patients in the control arm and 5% in the treatment arm getting intravenous TPA. So even though it was beyond 6 hours, those were patients that got TPA close to 4.5 hours. They were then transferred to a comprehensive stroke center. So at the time of randomization was after 6 hours. So comorbidities well balanced with the exception that atrial fibrillation was more common in the thrombectomy arm. As you all know, atrial fibrillation correlates with worse outcomes after thrombectomy, higher chances of mortality, symptomatic intracranial hemorrhage, lower chances of reperfusion, and overall worse outcomes. So that doesn't really favor the thrombectomy arm. Overall, just like in diffuse 3, the cores were small, less than 10 cc's. About 3/4 of the patients were selected with CT perfusion, about 40% with MRI. In terms of the occlusion location, 20% of the occlusions were in the intracranial internal carotid artery, about 3/4 in the MCA, and you meant to exclude the M2s, and you had very few protocol violations, so just about 3% M2s, which actually compares favorably with all the other trials that aim to exclude M2s. So in terms of the mean time to treatment was about 13 hours. You can see here that the interquartile range was 16, so a quarter of our patients were treated after 16 hours, so at a time window that diffuse 3 did not explore. This was an interesting finding in the sense that you had more wake-up strokes in the thrombectomy arm, okay, than in the control arm. And you got some criticisms about that. And what I'm gonna show to you today is that those are the patients that actually have less benefit or actually have lower rates of good outcome. I shouldn't say less benefit, lower rates of good outcome. So this is actually, it's much better to have a witness stroke than to have a wake-up stroke. And I'll explain exactly why. It's a bit counterintuitive, but I'll explain why. So in terms of the procedure duration, less than 1 hour, about median of 2 passes with the trival device. The recanalization rate was actually surprising high at 84%. We always felt that the longer that clot had been in the brain, you would have more hydromechanic, you know, the water hammering effect of the blood pressure would cause greater impaction of the clot, and that would make the clot retrieval process a little more difficult. As you all know, with intravenous TPA, now you have data from a great paper from South Korea showing that the longer the occlusion is there, the lower is the chance of reperfusion with intravenous TPA. So you felt the same thing would apply to thrombectomy, and you were surprised to see such good grades of a reperfusion. Having said that, even though you have that hydromechanical force, remember, these are all patients with a small core, and the only reason you have a small core in a late wind is if you have good collateral flow. So blood pressure is pushing the clot in, collateral flow is pushing the clot out, and that may be the reason why retrieval was not more difficult in this patient population. So going to the co-primary endpoints, the average day 90 weighted MRS was 5.5 in trival, 3.4 in the medical management. This was highly statistically significant. This is the Bayesian probability of superiority. For those that are not familiar with Bayesian design, this translates in a very small p-value, just like what you see here. A little easier to understand is the day 90 MRS 0 to 2. That was a mandate for the FDA, about 49 versus 13%. With a treatment effect size of over 35%. This is the highest treatment effect size ever seen in any acute ischemic stroke trial. We had an NNT of functional independence of 2.8. We are very proud of that. However, what this demonstrated is that you were highly over-selective. In reality, you should have used much broader criteria to actually show you could have benefit many, many more patients. So in general, I'm very much against restricting ourselves to the DOM or diffuse 3 guidelines, because a number need to treat of 2 or 3 is simply wrong. Okay, if you aim for that, you are excluding many people who would benefit from that treatment. Here is the shift analysis, okay, and you can see the number need to treat to have any improve in the disability scale of just 2. I mean, this is better than antibiotic for sepsis. Again, over selection, okay? You probably can afford treating sicker patients with larger infarcts. and you can see the highly statistical significance here. In terms of secondary endpoint, those patients were 2.5 times more likely to experience extreme early improvement. In terms of the 24-hour CT angiogram, the chances of recanalization was 100% higher. Infarct growth was almost like no in the thrombectomy arm, and then you can see here a pretty dramatic increase. But what you actually learn from this trial is if you have good collaterals, which many of these patients had, at 24 hours, your infarct has not grown yet. I mean, you can see here a 22 cc infarct size. This is not a big infarct. These patients had 13% good outcome rate. So their infarcts, it's actually a lot bigger, and you are now in the process of trying to get scans from 3 to 5 days. So in our center, what you saw is when you do a scan at 24 hours, the infarct had grown a little bit, but then when you repeat the scan at 3 to 5 days, it was massive, suggesting that the window of opportunity in some patients is actually way beyond 24 hours. So in terms of safety endpoint, you can see here numerically lower stroke-related mortality in the thrombectomy arm, but that was not statistically significant. The rates of symptomatic intracranial hemorrhage were not statistically significant difference. What was statistically significant different was the early of neurological deterioration being almost twice as big in the treatment arms. No-treatment arm, in the control medical arm, these patients tend to get worse. The rate of ENT, as in other trials, was less than 4%. So the safety outcomes essentially demonstrate no safety concerns for late thrombectomy, right? So there is no reason not to do this because people bleed more or have more complications. That's not the case. In terms of subgroup analysis, you look at age, and you could easily demonstrate that the treatment effect size is actually very similar across age. It is true that the older patient does worse with thrombectomy, but without thrombectomy, they have almost no chances of a good outcome, right? So, and it's all not about the absolute chances of having good outcome, but about the treatment effect size, which is actually pretty big in the elderly population, as you can see here. In terms of stroke severity, the same thing. You look at NIH 10 to 17 versus greater than 17. And if you look at either the 0 to 2 independence at 90 days or the utility weight average, you can see that the treatment is maintained and there is no interaction between treatment effect and stroke severity. In terms of baseline core volumes, you can see a benefit throughout the entire spectrum. We had very few patients with large core, very much like in the FUSE 3, even though they went all the way to 70 cc's. We don't have great data now on the larger cores, but all the way to 40 cc's, you can see a largely statistically significant effect here. What about the clinical core mismatch paradigm? Those three subgroups, again, very well sustained across all the types of clinical core mismatch, and doesn't really matter if you look in terms of dichotomized MRS or the utility-weighted MRS. Those effects are pretty much sustained, and there is no interaction between treatment effect and the type of clinical core mismatch subgroup. Mode of presentation. So very much like there are several types of outcome measures, you need to understand that in stroke now we have three very important time metrics. So you have the time that the patient was last seen well, you have the ictus time, and you have the time that symptoms were first observed. If you have a wake-up stroke, these times are all different, right? If you have an unwitnessed stroke, these times are all different. However, if you have a witnessed strokes, they are equal. So it's very important to kind of understand which time metric we are talking. And then in the down trial, the randomization was made according to this, but you had a pre-specified analysis looking at time lasting well, but also time symptoms first observed. So here is the split between wake-up, witness, and unwitnessed strokes. However, you see a lot of wake-up stroke patients here, but many of these patients were treated after 6 hours. Why? They had a wake-up stroke, they went to a primary stroke center. People didn't know they could do anything. They finally realized, well, these hospitals are doing a new study. And then by the time that the patient gets to new hospital, it's been more than 6 hours since the patient has been diagnosed with the stroke. Okay? So what you have here is the mode of presentation, wake up, unwitness, and witness, and some comparisons. And again, you're looking at dissecting out the data in several different ways here. But when you look at the unwitnessed patients, in general, they were older, and they had the higher NIH stroke scale and later presentation. So it's just important to keep that in mind, okay? But then when you look at the outcomes, okay, just as I said, so the big criticism was you had more wake-up strokes in the thrombectomy arm. Well, it turns out that the thrombectomy arm is not benefited by wake-up strokes. They are actually benefited by witness strokes, okay? And you will explain why that is the case in a little bit. But again, the idea that you had more wake-up strokes actually, if anything, would have hurt us because witness strokes are the one who have the best outcomes, okay? And you can see here that even in the medical arm, the witness strokes is also the ones that have the best outcome. So it's fascinating that the strokes that we know are longer in duration are the ones that have the best outcomes. And we will explain why that is the case. So when you look at the treatment effect, it's pretty sustained across all types, right? And you can see here that if anything, and again, these are not statistically significant difference, but the one that numerically has the highest treatment effect size is the witness patient. The reason is because they have better collaterals. I'll explain that. Mode of presentation, when you look at the different types of mode of presentation, wake up, witness, and unwitness, they don't bleed more, treatment and control, but because the unwitness had older patients and more severe strokes, they had more hemorrhage than the other subtypes. Not necessarily because the subtype itself. Okay, so here what you have is witness versus wake up in the DAWN trial. So I want you to focus on this. 64% good outcome in the witness treated with thrombectomy versus 49, so numerically higher here. But again, the control you also see numerically higher in the witness. So the witness patients are the ones that you know have definitely strokes that are greater than 6 hour duration. So how is that possible? Remember the formula that you discussed, the equation you discussed in the first day, right? All these patients have small stroke volumes, around 10 cc's of median. If you have longer time of ischemia, the only way you're going to have a smaller stroke is if you have better collaterals. And that's why witness patients overall do better than wake up and unwitnessed patients, because the longer is the duration of the ischemia, assuming you have the same stroke size, the only explanation for that is better collaterals. Okay? And actually, if you go now to the diffuse tree trial, you see the same thing. Thrombectomy patients that were witness had better outcomes than the wake-ups, and you can see that not only in the thrombectomy, but also in the control, the outcomes are better. And again, the explanation is this: longer times, you have to have better collaterals in order to still have that small infarct, and that's why those patients actually benefit better. So even though you may think, well, it's better to have wake-up strokes because they are earlier strokes, it's because we're always thinking about time. We really have to break that paradigm and start understanding it's not only time, it's collaterals also, it's the ratio between them. Participating sites, we look at sites across volumes, and then the benefit was maintained. Emory and UPMC enroll a lot of patients. We exclude Emory and PMC, and then we still have had great results. And the subgroup analysis is pretty much like, just like in the HERMS cohort, you can see that all point estimates favor thrombectomy. And that goes for utility-weighted and dichotomy. We talk a little bit about the effect of time to treatment, starting with time lasting well. You can see here, this is the probability of full independence at 90 days. This is time. You can see that in the thrombectomy arm, maybe if you force the model in a linear regression, which is in general a good idea. You can see that maybe there is a line that you can see in the control, and then if you compare the treatment effect size early and late, maybe it's decreasing. But when you actually look at this more carefully, there is no statistical significance to this line, and there is no statistical significance to this a difference. So the much better way of looking at the data is what you discussed on day one, right? So here you have the utility-weighted MRS going from great outcomes to bad outcomes, or the MRS going from great outcomes to bad outcomes. Blue is treatment, red is control, and the lines are the averages of these scatter plots. And when you compare the treatment line with the control line in this much more accurate model, you don't see anything going down, and you don't see these lines crossing or decreasing, right? If anything, it looks like the treatment is actually very well maintained, and although you know that there is noise and you see the 95% confidence interval crossing, there is absolutely no hint that time plays a role here. Why? Because all these patients have a mismatch. So you look at the 3-hour time intervals, and you can see, again, no effect of time with statistically significant benefit all the way to 21 hours, even just looking at this low time epoch of 18 to 21. So it's pretty impressive how powerful this treatment is. When you look at the treatment effect, over the time lasting, well, 6 to 12 versus 12 to 24, again, no impact of the, no interaction across treatment effect and time epochs. Time symptoms observed, so that was time lasting well. So first thing I would like to highlight is that almost 40% of the patients in the Dawn trial had time symptoms first observed with a stroke, to randomization greater than 6 hours. So you actually have a fair amount of patients that we know were treated beyond 6 hours, okay? And then when you look at found less than 6 hours versus found greater than 6 hours, you can see that the treatment effect size is actually numerically higher in the patients that are treated late. So there is, again, no hint that time, if you have a mismatch, matters, right? So at the idea that the time resets the clock. And then again, look at time since first observed, 0 to 6 versus greater than 6. You can see here no interaction with this time epochs and the treatment effect, okay? If anything, the later time has numerically higher effect. And when you do the univariate and multivariate analysis, you can see that time actually doesn't come up in the model. What comes in the model is age, NIH, thrombectomy, and diabetes only. So I showed this on day one, looking at all types of outcomes, looking at the 2 times of ways of analyzing time. We have no statistical significance for time importance in this trial. Same thing was seen in the diffuse trial. You don't see the effect of thrombectomy going down with time. And we talk about this in the first day. Maybe what you see here is that mismatch resets the clock. But remember, we didn't really track the incidence of mismatch over time. We know that the benefit of the therapy is sustained, but the chances of having a mismatch, of being a candidate for downward diffuse tree, will decay over time. So time is still brain. So the next question is how generalizable the data is, right? So you're very lucky that in conjunction with the Dawn trial, you had a large registry called the Trival Registry, where you had over 2,000 patients treated. And then what you did here is out of these 2,000 patients, you got the ones that look like the Dawn patients, meaning NIH stroke scale equal greater than 10, just like in Dawn, same type of occlusion, intracranial ICA M1, and same baseline MRS. We had almost 1,000 patients with 280 late 6 to 24 hours and 710 patients 0 to 6 hours. We had outcomes in almost every patient, and you could compare late versus early patients. First thing that becomes apparent here, and this predates Dawn and diffuse 3, is that you are actually close to losing equipoise. If you look at the whole cohort of almost 1,000 patients, over a quarter of the patients, almost 30% of the patients, were already being treated beyond 6 hours. So this tells you how common this scenario is going to be in your practice. A lot of these patients. So what I would like to show you, and you're about to finish, is that we have the early window phase 4 data, and you can compare with the early window phase 3 data, like SWIFT Prime. And look, the age is very similar, the NIH is very similar, the site of occlusion is very similar, but the overall outcomes almost mirror each other, okay? Symptomatic intracranial hemorrhage, good outcomes, and mortality are amazingly similar. So you have the bigger registry of 710 patients doing an external validation of the smaller number of treated patients in the trial. And the same thing you have with the registry here in the late window, the trivial registry 6 to 24 hours, with the Dawn trial. Similar baseline characteristics and similar outcomes. Look, 49% versus 50 good outcomes. So it's externally validating the data. So now we have 3 big pieces of data for late window. We have Dawn randomized, you have diffuse 3 randomized, and you have the late cohort of the trivial registry. So diffuse has been published, and it's very complementary. It confirms our results and complements our results. They have a shorter time window, but they put less severe patients, slightly bigger cohorts, and it's very nice because we are lucky enough to have 2 randomized trials, which is what you need for level 1A data. So when you look at the diaspora of our clinical trials here, you can see the Dawn trial here with the largest treatment effect size, okay, reflecting that you were over-selective. You should actually have treated more patients with broader inclusion criteria. But the main message here for me, it's actually the control. What you now know is, if you have a high NIH stroke scale, even if you come up with a little tiny stroke, and you don't get TPA, these patients have terrible outcomes. So it's our moral obligation to treat acute ischemic stroke patients with high clinical severity who can't get TPA in a very aggressive manner. You should treat more of them, okay? And there is the late window paradox, where again you see the treatment effect size of Dawn and diffuse 3 being actually higher than HERMS. And again, the reason for that is probably because these patients here didn't get TPA, so the control arm is going to be worse. So TPA works for large vessel occlusion, it's just not as good as thrombectomy. We expect a 40% increase in the incidence of thrombectomy. This is independent work done by the Cincinnati group. And then to conclude, time is brain, but so is collateral flow. The clinical core mismatch seems to predict treatment response in an independent manner from time to treatment, right? So 2 ways of looking at patients, time is brain and mismatch is brain, just like we talked the other day. And finally, time should no longer be a disqualifier for thrombectomy, but rather only a very important source of urgency. Even though you can treat patients in the late window, that doesn't mean that you should do that treatment in a slow manner. The faster you treat them, the better will be their outcomes. Thank you very much for your attention.
Thanks, Raul. Really appreciated, really nice, crystal clear. We are late, but I think we have time for 1 question from the floor. Anybody who wants to ask?
Thank you very much. Very nice presentation, Mauro Bergui von Turin, neuroradiologist. Don't you think that during the time passed from the first trials, the time variable is confusing and is becoming more and more unuseful? You may simply use the CT scan and simply forget the time. 1 hour, 6 hours, 24 hours is the same, provided that you have a large vessel occluded and a small CT scan lesion.
Fully agree. I think if you have a high clinical severity, a large vessel occlusion, and a small stroke, time is irrelevant. So that's the idea that, as long as you have a mismatch between the clinical exam and what you see on image, and by the way, image does not need to be CT perfusion or MRI. If anything, a CT scan at 14 or 16 hours is more specific for ischemia than a CT scan non-contrast early on, right? So if you can get in your hospital, this perfusion software is great, but I don't think it should be a mandate, okay? Because if anything, non-contrast CT later on is more specific and sensitive for ischemia than early on. So it should not be a mandate, but rather an option. I fully agree with you. Glad that you came to that conclusion through your observations in the clinical trials. I think that's where you're heading. We've been so focused on time because the thrombolytics are very sensible to time, risk of hemorrhage and all that. But I think with thrombectomy, you really need to change that thought process. Thank you so much for the attention.
Can I add something? How, in fact, do you select patients in your institution, apart from trials, and what's your real-life approach?
Yes, so we talked a little bit 2 days ago about when I know the patient has a stroke, they just come straight to the angio suite and you do that multi-phase CTA. Other than that, you are in a big academic center, you do a lot of research, so that's why you acquire imaging. But I think for clinical practice purposes, if you are not participating in clinical trials, I would say less is more. What you need to do is treat the patient very, very fast, okay? In general, I think in the future, you're not gonna be taking patients to the CT scanner anymore. I think that you go straight to the angio suite. We're gonna have to have more people treating patients. You're gonna need to have more angio suites, but just look at what interventional cardiologists do, right? And I think that's our future. Thank you very much once again.
Thank you very much. Thank you very much.